So we are live in 3, 2, 1. Please start. So we are live.
A very good evening to one and all, and I welcome you all for today's webinar on biomarker testing for NSCLC in 2023. With immense pleasure, I would like to invite Dr. Nitesh Rohatgi, who is Senior Director, Medical Oncology, Fortis Memorial Research Institute, Gurugram, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
I'm sorry about that. Am I audible?
Yes, sir.
Okay. Well, welcome again, Dr. Nitesh Rohatgi, and really a big welcome. Biomarkers in non-small cell lung cancer 2023 seems to be the hot topic, but we were just still scratching our head on what to do, and I think EGFR was the poster boy for this. Not only are we looking at more biomarkers, and we're also looking for biomarkers for resistance and for second therapy and third therapies now, but we are very quickly learning the real use of liquid biopsy, which is taking over solid biopsy, at least in the lung cancer world. In diagnosis at places, yes, but more so in resistance, it's becoming a very center stage, especially in lung cancer where often tissue is a big issue. And I think the more we are using, the more confident we are getting about its overall use for the targeted therapy in lung cancer. I think we are joined by an extremely who's who of lung cancer in India. Kumar Prabhas, who we all know very well, is the professor and head of Department of Medical Oncology and represents India on the map of lung cancer. Is going to join us a little later, and I'm pitching in on his behalf to do the introduction today. Of course, Ullas Batra, the co-director of Department of Medical Oncology and Chief of Thoracic Medical Service, will be obviously doing the moderation. Navneet Singh, professor of Department of Pulmonary Medicine at PGI, Chandigarh, has done the thoracic oncology of India so proud in the recent past, and he is innovating, and his entrepreneurial approach at PGI is to be applauded at best of times. Amit Rothan, HOD and consultant Department Medical Oncology, is going to be the first one driving the talk, and I think his passion it puts me to say shame sometimes. he is so passionate about lung cancer, about target therapies, about liquid biopsy, that there's a lot to learn, and I look forward for his lecture. Dr. Nitesh Rohatgi, which is me. I will not talk about myself. Dr. Jyoti Wadhwa, a very close friend, Senior Director, Department Medical Oncology and Hemato Oncology. I think it says Medanta Medicity. I will ask her to tell us where she is now. Again, very experienced and a great set of learning about how to put science into practice. Dr. Neeti Raizada, Senior Director, Department of Medical Oncology and Hemato-Oncology at Fortis Hospital, Bengaluru, completely passion-driven about both the science and how to put bench to bedside. Dr. Vijay Patil, of course, at Hinduja Hospital, and a great opinion on various aspects of medical oncology, including lung cancer. And last but not the least, Dr. Kaushal Patel, Senior Consultant at HOD at the Department of Medical Oncology at Adventist Hospital and Surat, and really looking forward for your opinion as well. But I think we'll start the talk with Amit Rothan, who we all know, and looking forward to listen to his talk on the day today about the genomic landscape of non-small cell lung cancer in India using the liquid biopsy, and he's got a paper on that, and we want to see his views as well as his paper on this. So Amit, over to you.
Good evening, everyone. Thank you, Dr. Nitesh, and thank you, Garden, for this opportunity. I'm going to... Nisa, could you share the slides? It's...
Yeah. Sir, shall I share the screen?
Yeah, that will be great.
Okay, okay, sir. Okay. Give me a moment, sir.
So what we will be doing is, I'll kind of share with you this. This was a poster presentation in ESMO Asia, which was presented in December 2022, where we looked at genomic landscape of non-small cell lung cancer in India using the Garden 360 in clinical practice. Yeah, next, please. So this is a collaboration between a lot of people, some of them here, some of them not here, but a lot of data has been put together, and I actually thank Dr. Nisarg and his team at Guardant. All of them have done this work, putting on data, collecting data from all the oncologists who have been using Guardant 360. And this is not a study per se, where this is just looking at all the pooled data which was there and analyzing that for seeing what are the mutations we are seeing in our population in India. Next, please. So our objective was to investigate the landscape of clinical relevant mutations in cell-free tumor DNA from non-small cell lung cancer patients in India, which was tested by Guardant 360 as part of clinical practice. Next, please. So there were 120 patients who had been tested, and all of them had advanced lung cancer. All of them were, most of them were adenosquamous. We did exclude neuroendocrine carcinomas and small cell carcinomas. Pure squamous histology was excluded. A pure sarcomatoid was excluded, but I don't know, because it's very difficult knowing the data from multiple centers about the histopathology exactly. What we're looking for was looking for the relevant biomarkers which are NCCN approved into practice. So we're looking for the mutations in EGFR. We're looking for MET exon 14/6 skipping amplifications, and then looking for fusions of ALK, ROS, RET, and NTRK1. Now, next, please. So VUSs were excluded. So this is the Guardant 360 test, and this is what it all looks for. You're looking for those mutations. There's 74 genes which are being looked at. There are 18 genes for amplifications, 6 genes for fusions. And of course, we get the MSI information also from this test. Next, please. So this is the spectrum of alterations which were detected in these 120 samples which were done. And what we see was, you look at a wide variety of mutations, and this is what we always say, you end up getting a lot of mutations these days when you do an NGS testing. Some of them relevant, some of them not so relevant, some of them are mutations which you don't know what to do about. But this is the spectrum of mutations which you see. And out of these, the largest number of mutations, what you saw was P53 mutation, which almost reached 50% of patients. Of course, that's not a relevant mutation in terms of targeted therapies, but it is important and becoming more and more important as a co-mutation, and in future would help us in guiding therapies also. EGFR was the commonest mutation. ERBB2 surprisingly was right there, and there was a whole list of mutations. Next, please. If you look at the percentages of the NCCN guided genes which we talk in clinical practice, so out of the 120 patients, EGFR mutation was the commonest. We had 34 patients, so that's about 28% of patients having an EGFR mutation. Very surprisingly, ERBB2 mutations, we picked up 14 patients. So there are 11% of patients who are having a HER2 mutation. Now, this actually caught us by surprise. I really didn't think we'd have such a big number of HER2 mutations. Of course, again, keeping in mind, this is not a clinical study of a sample size of population. This is just tests which have been sent to a lab, and the lab is looking at their data. A lot of bias, but even in that, seeing ERBB2 mutation at around 11% is quite a high number. MET alterations were seen in about 8 patients. That's about 6% of patients. Some were exon 14 skipping mutations. I think there were a couple which were amplifications there. KRAS mutations were seen in 5 patients. That's 4% of patients. And these are all KRAS G12C mutations in these 4% of patients. BRAF V600E was seen in about 4% patients. RET alterations were seen in 2.5%. ALK was seen in 1.6%. ROS was not seen in this study, though there was one patient who had a ROS alteration, but again, it was said to be below the threshold of reporting. So again, on the repeat test, it turned out negative, but there was one, and there were no patients with NTRK fusions in our 120 patients here. Next, please. So these are this is basically the main comparison of the frequencies which came out. We do believe there was some studies from Southeast Asia which were looking at EGFR, saying about 48% had EGFR when they had used the same kind of a liquid biopsy testing. Again, I think in India we talk about 30 to 40% of patients having EGFR mutation. I think we are right there, about 30%. And again, maybe when we do a study, a proper study, we'd probably find the exact numbers. Next, please. So we had about 28, 29% of patients with EGFR mutations, and a lot of patients had co-mutations. And that is what was looked at. About 38% of patients had a P53 mutation. There were other mutations. You had 8% having a ERID1A simultaneously. You had 8% having a PIK3 mutation, or maybe 2% having a RB mutation. You had some patients with CDK, and with ERBB2 simultaneously, 2% having an FGFR mutation simultaneously. But again, telling us, when we are doing hotspot testing and we only look for EGFR, that becomes that we have an EGFR mutation and we don't know what co-mutation we carry. Nowadays, a lot of literature is also going into importance of co-mutations, especially if we have an EGFR mutation and if we have a TP53 mutation, probably they will not behave the same way as if we had an EGFR mutation without a TP53 mutation. So this information is important. And I'm sure as we go forward in time, we won't be treating these patients the same way. It's probably, my thought is, we know these patients will behave a little more aggressively than the other patients. And with the more and more data coming in about combination therapies or newer therapies, a lot of thought will go into importance of co-mutations with an EGFR mutation. So that's where I think we have a lot of relevance of doing NGS testing upfront rather than testing just for EGFR Alcross, what we used to do. Of course, nowadays, a lot of people and a lot of us do limited lung cancer NGS panels, but it's still important to pick up a wide variety of Q-mutations, and all of these may have importance in treating our non-small cell lung cancer patients in future. Next, please. We were also looking at, because 50% of our patients had a P53 alteration. So you're looking at, again, if there was a P53 alteration, what else did they have? And about 36% had an EGFR, 22% had an ERBB2, about 2% had a MET, Alcross. So what you're seeing is, many of these mutations, when you do a broad spectrum NGS panel, many of these mutations go together. Not one clean mutation many a times. That's what we keep very limited. So we used to think we'll get a clean ALK there, we'll get a clean RET. We used to hope that way that we'd see only a clean mutation. But what we end up seeing is, in broad spectrum panels, you are definitely picking up a lot of co-mutations, co-alterations of genes are being seen. Again, some of them may be relevant, some of them may not be relevant in practice, but it's good to know all this information. Next, please. In the EGFR mutation also, there was data looking at the types of EGFR mutations, the common ones, the 19 and 21, and also looking at the uncommon ones. And also, of course, there was a lot of interest looking at exon 20 insertions. That is the hot topic these days, looking for exon 20 insertions and seeing whether they can be targeted. So that was something else also being picked up. Next, please. What we did see in all these samples, the commonest one we had among all the EGFRs were the exon 19s, and that's what we see in practice. The next one is the exon 21 mutations, which again, these are the common things we see in practice, the 19 and the 21s. We did pick up the uncommon mutations also, and we did pick up a group of insertion 20s also. So this is important now that we have drugs for exon 20 insertions. So it's good that by this kind of a testing, we are picking up this patient samples also. Next, please. There were observations of how much time does it take to get the test. So medium turnaround time was less than 7 days, and that's very quick. And I think this is probably the most important incentive which puts me to kind of testing for the Guardant NGS blood testing. Whenever I do a blood NGS, the reason to do it is that you get a very quick answer. You need the complete information. You need a very reliable explanation. It should be well validated, and it should come in time. So this is what was very good to see. Sometimes we say in practice, it may take us 9 to 10 days, depending on when we send the sample. But we see that in practice within the first 10 days, we have the report when we send the blood NGS with the Guardant 360 test. There were 6% of patients who had no mutations detected. Now, that is something that we always worry about, that because if you send a blood sample in blood NGS and you don't get a mutation, you always know it's not that you don't have a mutation. It's maybe because it's not shedding, it's not picking up. It could be the test problem. It could be the timing problem. So there are a lot of issues there. But again, you kind of always think in your mind, how many would you miss? But it is good to see that there were only 6% of patients who came back as no mutations detected. And again, we do know that when we see no mutations, at least with Guardant, we are repeating a sample, and we repeat a sample again after a few weeks or in a month time to see again, pick up another sample, test it again, and see whether there's another mutation. Either is it not shedding, or are we not picking up due to any reason? The median variant allele frequency was 0.04%, and at least one clinical relevant gene alteration was seen in 50% of samples. And I think this is where we stand in clinical practice presently when we talk of mutations for lung cancer. Yes, tissue NGS is the standard, we say, but these days, so often we start off with blood NGS because we get it quickly, and in 50% of patients, we are picking up mutations, and we know we have a validated test to get these so that we can start patients onto treatment immediately. Next, please. So coming to limitations, again, there is obviously limitations here. This is not a study per se, which is trying to answer what is the mutation frequency in India or any of that sort of information. It's a very small sample size. There's not much clinical history or testing history on these patients. It is not that the patients have been tested upfront or tested at progression only. These are just samples which are coming. So this could be some patients who are upfront. Some people are sending it at progression. Some people are sending it after multiple progressions. Some people are sending it after getting some testing negative on tissue and then doing reflex testing. It's just a sample size which has been taken up at one time frame and looked at what all frequency we saw. So this is not, I wouldn't say this is a reflection of the frequency of mutations which we see in the Indian population. I don't think we should say this at all. What I would just say is, we know we are picking up all sorts of alterations, and we know we are picking it up rapidly, and we know these are all targetable. So we know we are getting a quick answer by doing a blood NGS test, and that's where the importance lies. Next, please. So this is the conclusion. We saw clinical relevant biomarkers detected in more than 50% of our patients when we did this as a Guardant NGS testing. This study clearly showed it. I was pretty much surprised by the amount of HER2 mutations we have picked up. And I'm actually surprised in the last couple of years, we have a big number of HER2 insertions we have picked up. And I myself can tell you, I've picked up a couple of patients whom we have treated with Enhertu and who are doing very well for some time now. So it's really relevant in practice. And that's where the whole thought comes. We do think of EGFR, yes, but we know many of our limited panels when we do NGS testing actually doesn't have HER2 mutation there. They have the other mutations, but many of them don't have a HER2 insertion 20 mutation. So the ERVV2 mutation is something we are missing, and that's why probably we were surprised by the amount of numbers we picked up when we are doing a broad spectrum NGS panel. And this is definitely targetable, and we are seeing responses in our patients. Using a single assay test with less than 7 days of, or I would say less than 10 days turnaround time is really good in clinical practice. There's definite advantages to that. And I think all of us are very happy with that kind of turnaround time. And so this clearly shows that plasma NGS can be integrated into diagnostic paradigms in India. Many of us have already done it. Many of us are doing it. Everyone has their own way of using liquid biopsy and blood NGS. There's no right and wrong there. Everyone has their own perspective depending on the patient experiences they have got from NGS. We, as a center, are very strong believers of blood-based NGS upfront, and that's what we do in practice because of the number of things we have seen and we have been able to utilize for our patient practice. Thank you very much. Thank you.
Thank you for that, Amit. Really fantastic, I think, poster. I'll let Ullas discuss some aspect of it when we do the panel discussion. I believe Dr. Kumar Prabhas has joined us. I welcome Kumar, very close friend. And obviously, I think he needs no introduction. He is the professor and head of Department of Medical Oncology at Tata DMH. And of course, as I said before, leads lung oncology for India. Am I audible again?
Yes, sir.
Yes, sir, you're audible, sir.
Okay, so I was just saying, I don't know if somebody heard me, but I was welcoming Kumar to take it forward from here and invite Navneet for his talk. Okay, maybe Kumar is not there. Can I invite Navneet for his talk? Navneet is the professor of Department of Pulmonary Medicine at PGI Chandigarh, and needs no introduction, as I said before. He's going to be talking about biomarker testing in non-small cell in 2023. Over to Navneet.
Thank you. Okay. I need to be given the rights for screen sharing, please. Okay. All right. So visible, audible?
Yes, sir.
Yes, sir.
Good. So the topic allotted to me was biomarker testing for NSCLC in 2030, and basically a focus on the recently published Asian consensus recommendations. Okay, so 3 of us were part of this consensus development, Dr. Kumar, Ullas, and myself, along with a host of people from different parts of Asia. This has just been published online in ISLC's official journal, the Journal of Thoracic Oncology. So the background is that most published guidelines for genomic biomarker testing reflect the disease epidemiology and treatments in Europe and North America, but 60% of annual global cases now occur in Asia. And we know that the patient characteristics, the molecular profiles and treatments can vary from a small extent to a vast extent as compared to Europe and North America. And the classical example of this is the frequency of EGFR mutations, which is much higher in East Asia compared to Europe and North America. And obviously South Asia falls in between that. And as Amit said, it's roughly around 30%, while the figure goes to around 50 to 60% in East Asia. So these consensus recommendations were basically from clinicians or lung cancer physicians in Asia in an attempt to improve patient care. So we now know that there are currently 10 biomarkers which can or should be tested. Obviously, there are 9 of these are driver alterations. PDL1 is a biomarker for immunotherapy, and among these 9 alterations, there are mutations, 5 of them, EGFR, MET, BRAF, ERBB2, and KRAS, while the other 4 are fusions or alterations, which is ALK, ROS1, RET, and NTRK. And obviously, you have different methods for testing each of these, ranging from simple immunochemistry to Sanger sequencing, the old initial method, to real-time PCR, and finally the standard of care, if you may want to put it, X-generation sequencing. So coming first to non-metastatic setting, and this is resectable NSCLC. So the recommendations for this is that if you have adenocarcinoma stage 1A, as a routine, neither EGFR nor PDL1 needs to be tested. This is simply because stage 1A is has been shown that curative intent surgical resection is enough. Now, if it is above stage 1A, then the recommendation is to evaluate EGFR by PCR and PDL1 by immunohistochemistry at diagnosis. And if the tumor is positive for either EGFR or PDL1 is more than 1%, follow the local treatment recommendations. I just need to re-emphasize, these are recommendations for testing. They are not recommendations on how to treat patients. And therefore, all of these are going to be centered on what to test and when to test and how to test. Similarly, if you come to squamous cell carcinoma, and by squamous, basically it means pure squamous, in which you are not suspecting an adenocarcinoma component, either based on the clinical profile of non-smoking or gender. So if it's a pure squamous cell carcinoma, then 1A to 3A EGFR testing as a routine is not recommended, and only PDL1. For 1A, obviously, PDL1 testing is not recommended the way it was for adeno. And this algorithm kind of puts it very simply, what is to be tested. And based upon the testing, you follow the appropriate treatment recommendations. Now, a turnaround time of around 3 weeks for these results is deemed to be acceptable when it is from resected tumors. Next, if you come to non-metastatic unresectable setting, and so if the patient is fit for definitive chemo radiation, then one has to consider evaluating for PDL1 status regardless of histology, and in cases of adenocarcinoma for EGFR mutation as well, and then follow the local treatment recommendations. If the patient is not fit for definitive chemo radiation, then one would tend to follow the testing recommendations for metastatic disease, because in a way, the treatment would also be on those lines. Now, because these are unresected tumors, the tissue biopsy used for diagnosis is typically used for biomarker assessment. And here, just owing to the urgency of treatment, a turnaround time of less than 2 weeks is preferred. Again, this is a algorithm which summarizes all of this, basically both for early stage and for advanced, locally advanced stage. The 2 biomarkers which have been recommended are PDL1 and EGFR, with the latter being limited to adenocarcinoma or non-squamous histology. Now, once you come to metastatic disease, again, tumor tissue is the preferred source of material for both confirmation of the diagnosis and initial biomarker testing. However, sometimes the availability can be a issue. And in such cases, the tissue should be prioritized for biomarker assessment that can be performed only with tissue, such as PDL1 testing. Because the other markers you may attempt in liquid biopsy or NGS. Having said that, and this is not part of the recommendations, we know now that even PDL1 testing is being attempted and being validated in CTCs. Next is that the analysis of ctDNA has emerged as an effective and promising tool for genomic profiling in metastatic disease. And evaluation of CTD can be particularly useful in situations where the tissue biopsy is not safely obtainable owing to poor physical condition of the patient or a tumor site which is not very easily accessible. Now, the detection rates of actionable genomic biomarkers are largely similar between NGS-based ctDNA assays and tissue-based methods. In fact, going one step further, one can always say that both of them are complementary to each other. And if you were to do both instead of one, the pickup rate would perhaps be higher. Coming back to the recommendations. So in addition to identifying oncogenic driver mutations that can be treated with targeted therapies, ctDNA may also prove useful in novel ways, including monitoring during patient's treatment course, and that would indicate a real-time monitoring, as well as for determining mechanisms of resistance to treatment. So coming first to adenocarcinoma histology, and the recommendation is that all patients should be tested simultaneously for the three important driver alterations, which is the EGFR mutations, ALK and ROS1 rearrangements, and PDL1. And you can go about doing this in different ways. So one is that you do standalone testing for EGFR, ALK, ROS1, along with PDL1, of course. And if you detect a genetic driver, then obviously you follow the appropriate treatment recommendations. And if this initial standalone testing is negative, then you can go ahead with a multi-gene panel testing. Again, if the patient's conditions allows, one could wait for results of the testing to come in before starting treatment. Vis-a-vis, if you need to start the patient on some form of treatment, which is often the norm, then you go ahead and follow the treatment guidelines for genetic driver negative disease. On the other hand, one could go ahead straight and perform a multi-gene panel testing along with PDL1 and accordingly see if you found a genetic driver alteration or not, treat accordingly with targeted therapies, or if they were negative, then look at the PDL1 expression and decide whether you need to give immuno alone or immunochemo. The important thing to highlight here is that treatment decisions should not be based solely on PDL1 results. This is very, very important because PDL1 results often come in earlier. That is simple immunochemistry. ALK can often come in simultaneously with PDL1 because that is also IHC typically. However, EGFR is not IHC, it's either RT-PCR or NGS, and therefore it typically might come in later than the PDL1. So one should not jump at a PDL1 report of 80% and start immunotherapy unless you have seen the results of EGFR, ALK, and perhaps other driver alterations coming in and being negative. Wherever available, tumor tissue should be used for testing, but if tissue is not available or rebiopsy is not practical, ctDNA testing should be considered. Again, the recommended approaches could be a polymerase chain reaction or PCR for EGFR, IHC for ALK, and FISH for ROS1 rearrangements. But one can consider other methodologies such as NGS whenever it is necessary to cover along with these three other alterations. Now, importantly, EGFR testing should assess both the common and the uncommon driver mutations, including exon 20 insertions. And if there is a concern that the PCR can miss out some of the pathogenic alterations, then an NGS can be considered. Now, obviously, wherever the relevant targeted therapies are available, one should make an attempt to test for potential alterations in all of these relevant 9 genes, which would, as I said earlier, would include not just EGFR, ALK, ROS1, but 3 other mutations and 2 other rearrangements. Importantly, if multiple genes need to be tested, then a panel test is better than a sequential single test for assessing, because it is not just the speed of testing, but it is also the tissue availability, which is better utilized by a multi-gene panel. Now, again, the preferred turnaround time for obtaining test results is 2 weeks or less. And what was also recommended or in fact was a negative recommendation, was that TMB and MSI is really not needed for lung cancer. Then was the question that if the initial testing did not provide an informative biomarker. So if in the absence of a driver mutation after initial testing, which was single gene testing, one could perform follow-up testing for other biomarkers. But if an NGS-based panel, either tissue or plasma, was used for initial testing, then a follow-up testing is not routinely recommended. For patients in whom the initial testing were standalone tests and a follow-up testing is being performed, it should typically be an NGS-based panel, either tissue or plasma based upon availability of tissue. This is just re-emphasis of the same thing again. For situations that do not require immediate treatment, one can wait for results of the follow-on testing before initiating therapy according to the local recommendations. And here also the turnaround time should be minimized, typically less than 2 weeks. But wherever you need to give immediate treatment, one is to follow the guidelines for the driver negative disease. Coming next to metastatic squamous, here all patients should be tested for PD-L1 in tumor tissue. What we all know that EGFR mutations can also be there in patients who are never or light smokers, or whenever based on clinical judgment. One should also consider testing for MET exon 14 skipping mutations, especially if a sarcomatoid histology is present. Testing for other biomarkers at this step was not deemed to be part of these recommendations. Re-emphasize the same thing again. If there's a clinical suspicion that it is not a pure squamous, it is either adenosquamous or with an adenocarcinoma component which is not being picked up on testing. Example, a peripherally located lung cancer, non-smokers. In our setting, typically females in whom the smoking is much less. One should follow the protocol for adeno. And same thing about the EGFR testing, whenever performed, should cover all of the mutations. Now, if the initial testing was, there wasn't enough tumor tissue, ctDNA can be considered and turnaround time again 2 weeks or less. What if the initial testing did not pick up a biomarker? Well, in contrast to adenos, a follow-up testing is not required if the initial testing did not detect a driver alteration. What about disease progression? So if the patient was an EGFR positive treated with the first or second generation TKI, then obviously T790M should be tested in ctDNA or a rebiopsy. But importantly, if the ctDNA is negative, then a rebiopsy should be done to see if the T790M is there in tissue or not, as well as to rule out other causes of resistance, including small cell transformation. If the initial therapy was osimertinib, then one could consider an NGS panel of either blood or newly acquired tumor tissue if feasible. Again, if blood is negative, one should do a rebiopsy and look for other mechanisms of resistance, including possibly histological transformation. For patients who had disease progression after other targeted therapies, the newly acquired actionable alterations are less common. But again, if resources are available, one could consider NGS panel testing on either blood or newly acquired tumor tissue. Turnaround time, again, recommended 2 weeks or less. For patients who had progressed on either immunotherapy or chemotherapy or both and no history of targeted therapy, if there was an initial complete biomarker testing done in the past, no additional testing is recommended. It was only if there was incomplete testing in the beginning or no testing in the beginning should one make an attempt to do a comprehensive NGS test in either newly or archived tumor tissue or in blood. And the turnaround time remains the same, less than 2 weeks being preferred. So this is the algorithm for following in case of disease progression. The 4 categories which I just alluded to: EGFR positive treated with first or second generation TKIs, EGFR positive treated with osimertinib, other targeted therapies, and finally non-targeted therapies treated with immuno and or chemo. So to conclude and for future perspectives, this expert consensus indicated that relevant genomic alteration assessment is necessary at diagnosis and at disease progression, considering the tumor histology and treatment history. Tissue-based tests are preferred, but in case of inadequate tissue samples or inconclusive results, or when a rebiopsy is not feasible, evaluation of plasma for ctDNA is a viable alternative. With an increasing number of genes to be assessed, a comprehensive genomic profiling using either tumor tissue or plasma is becoming a more efficient method at the time of initial assessment for optimizing turnaround time for results and sparing the tissue sample for other analysis. The recommendations provided are intended to help clinicians across Asia in terms of biomarker assessment. However, again, healthcare providers are also advised to consider the particulars of each individual patient, including clinical history, comorbidities, accessibility to treatments and testing procedures before making a final decision. This was all about the recommendations, my personal viewpoints, what to test, no matter what resource constraints. In our setting, given the high prevalence of approximately 30% of EGFR and around 10% for ALK, an RT-PCR and an IHC must be done. You have a little better resources, definitely do go ahead and do a PDL1. And no resources, go ahead and do an NGS along with a FISH for ROS1. When to test, preferably at initial diagnosis for all metastatic and advanced cases, and make simultaneously attempts to have a rebiopsy if an initial tissue was inadequate. And obviously on progression, which is a current standard for EGFR mutated, perhaps it will be for others in the future. Stage 3A or less, we have encouraging data to test EGFR and PDL1 as of now. I'm sure that will be discussed by Ullas further in the panel discussion. Small cell and squamous, and by squamous I mean pure squamous, nothing really to test, only PDL1 for squamous. And importantly, there is no need to access the primary site, which is lung, solely for the purpose of obtaining tissue for molecular analysis, provided the initially obtained specimen had adequate tissue. And last but not the least, no decisions on immunotherapy unless EGFR and ALK reports are available and negative. And I'll stop here. And thank you very much.
Thank you very much, Navneet. That was really brilliant. I'm sure Ullas will talk more about this. Can I welcome Dr. Kumar Prabhas? I welcomed it thrice on the show. I think I'll welcome him for the fourth time.
Thank you, thank you.
To take over from there. Thank you.
So these are the friends for not the more number of times they take your name, you feel better. And I have a second one. I can see Ullas there.
So, Dr. Kumar, am I supposed to take only Kumar, or shall I discuss something also over here?
As many times, I told you, it always makes me feel better.
That is what I discussed. No, what happens is anytime a patient comes over there, I tell Kumar. चलो ठीक ही अच्छा ही होगा, उनका नाम तो कम से कम ले रहा है. Okay. So this was fantastic. And can I please, so the panel discussion right now is liquid more solid in 2023. And my panelists over here are Dr. Nitesh Rohatagi from FMRI. Right, Nitesh, till now?
Yes, even yet. Yeah,
even as on 9th February, yes, in FMRI. And you can actually
till 2033, my guess is that's yes.
Oh, come on, I'm sure that is not going to be there. Okay, Dr. Jyoti Vadva from Medanta. Ma'am, good evening. Dr. Vijay Patel from ex-Tata, that is where I said from Hinduja. Dr. Kaushal Patel from Surat. Dr. Kumar Prabhas, Dr. Navneet, and Dr. Amit Rotan, please join the panel. And can I share my screen, please? Slides, please. Please give me the rights to do that. Okay, I think the more solid, I don't know about the liquid biopsy or not, but at least the panel over here is very solid. I mean, starting from Nitesh to Jyoti to Vijay, Kumar, Navneet, I mean, you got an who's and who of thoracic oncology in India, at least in this panel. So Garden doesn't require liquid they have got a great panel. So is everyone here? Dr. Kumar, you're there? Navneet, you're there?
Yes.
And Dr. Jyoti and
Your
Kaushal?
service.
Kaushal is looking very serious. Why so
Yes,
serious?
yes.
Okay, fine. You smile, no? It is at the end of the day we are enjoying right now. Okay, so let's just start with the liquid tissue. This is something which I got from Google. So this is something which I am actually liking, and that this moderation is about is liquid, the new solid in 2023. So, you know, my first reactions after listening to the previous speakers, especially Dr. Amit Rautan, about liquid biopsy was like this, wow. And whenever I think about a liquid biopsy, the patient thinks about liquid biopsy is like this. My subsequent reactions about liquid biopsy is, abhi ruko zara, I mean, sabar karo. We'll have to see, you know, let it stand the test of the time, and, you know, let's put the liquid biopsy to test and to see whether it's really that important or not. So let's start with that. The first law of oncology is that, okay, the first law of oncology actually is that the patient should not disappear faster than the tumor. The second law of oncology is basically you should do a biopsy. That is what I was told throughout our times, you know, when we were reading. But the second law of oncology always is that tissue is always an issue. You know, I mean, that is where everybody keeps on telling us. So let me start with Dr. Navneet. So Dr. Navneet, you're from a government sector. How many times tissue is still an issue?
It's pretty much an issue. There's no denying that fact. I mean, you will have reports. I mean, it depends. So you will have people coming in with a diagnostic procedure done outside and slides being submitted for review, and you get the diagnosis, and then the comment is there is no tissue left for molecular testing.
Yeah. So should we review it all the time?
I'm sorry.
Review karana. And
We always get it reviewed. That is the only. We don't insist on scans being reviewed, anything, but tissue we always get it reviewed. That's
always reviewed. Fantastic. Dr. Vijay Patil, from your previous center to your new center, Vijay, are you there?
Not so much of an issue.
Okay.
I have a pretty good intervention radiologist at present with me. So they remove that issue whenever I want. Not that an issue with me.
No, they remove it whenever you want, but how many times do you want to the review? So let's say one first biopsy has been done. How many times do you feel that out of 100 times an NGS not sufficient was there? Just a ballpark figure.
That happens in around 20 to 30% of the times.
So 20 to 30% is reasonably okay. And I'm sure, Navneet, is that the number the same for you? The number higher, lower?
Tissue not being there for molecular testing? Yeah, 30%.
30% of the time. Okay. So let me go to Dr. Kaushal. Dr. Kaushal, Surat, I am not calling any tier 2 city now, and definitely not anybody from that part of the India. So what is your experience about tissue being an issue?
Not much, actually, frankly speaking. In approximately 15 to 20% of the patient fail to get the NGS report on the tissue. Otherwise, with a good intervention radiologist, we can get the good amount of the tissue, and that is more than sufficient to get the NGS. So if 15 to 20% patient, definitely the figure will be the same as Dr. Vijay Patil.
You are getting a repeat biopsy done.
Yeah,
okay.
Absolutely.
Fantastic. And is that a concern? From you and from the patient point of view, or you just give them?
Yeah, absolutely. Not from me, but the patient, it's a definitely concern, because patient is not ready to get it done twice or thrice because of fear with the side effects and fear with the procedure also. So definitely it's an issue when it has to be done with the repeat.
So Dr. Jyoti has already unmuted herself, so she knows this question was coming on to her. So Dr. Jyoti, your center, Medanta.
Tissue is sometimes an issue. I would say 10 to 15% of the times. We have very good intervention radiology team, as you all know. But sometimes, you know, the tissue may not be enough to do the NGS, or sometimes the patient may be so sick that you don't want to subject the patient to a biopsy. Otherwise, more often than not, it's not an issue.
Okay, so I think tissue is an issue in around 20% to 30% of the times, and we do require a biopsy. So that is what the ballpark figure I'm getting at. So let me talk to Dr. Nitesh. Nitesh, so tissue being an issue is one. What are the other roadblocks that you face, theoretically at least, with tissue biopsy?
I think tissue issue is question at diagnosis, but also at follow-up. And that has been over and over addressed in clinical practice now, especially, you know, when a lot of patients are failing first-line therapy, even in targeted sphere. The second big problem is that panels are relatively behind evidence. So, like even Navneet was speaking about a pan-Asian guideline that you all were part of. And clearly the TMB and MSI was not being tested. But between then and now, FDA has approved, for the maybe right or wrong reason, that's a great debate, maybe for the wrong reason, but it has approved pembrolizumab for TMB over 10 for all solid tumors. So what I'm saying is, it's, yeah.
Navneet is waiting to answer that, but I think we'll let it pass. You tell me.
What I was trying to say is that when you do broad spectrum analysis, and for that, sometimes you need a lot more tissue, it does become difficult to get adequate tissue for a good lab to do the right kind of testing, rightly put formalin, heterogeneity, as you put in. All these questions come in, and do we trust not only the machine, but also the algorithm? So all of these are big issues, not only the tissue itself.
I think we are getting greedy, I mean, initially the thought was we were treating a patient on the basis of FNA.
Yeah, Ullas, that's because we have seen patients progress on chemotherapy and later turn out to be positive for something else. We have seen MET mutations and all kind of, even non-BRAF, non-targetable agents. So what you're saying is we are getting greedy because we've seen the efficacy of targeted therapy in every patient who we have tried, and that's why we are getting greedy.
Who says greed is bad? Greed is good. I mean, for the patient, it's very good. I mean, let the patient
okay, I
live for
buy
5, 6,
that.
7, 10 years. Greed is good. I mean, as long as it is for the patient, that's very, very good. I'm happy about that.
Okay.
Dr. Navneet, you want to take the question of MET and of TMB and this thing you wanted to answer that? For the guidelines?
I'm planning to answer, but TMB and MSI are really not needed for lung. I mean, even there are papers in which they have looked at the profile of MSI high across a variety of tumors, and lung falls at the other end of the spectrum, like maybe 1% or so. And I actually am quite happy with the recommendations from this consensus. We don't need to test TMB and MSI for lung at least.
So agree with you.
I agree with Navneet 100%. I'm just in a dilemma right now where a report comes with high TMB and the patient comes and says, but there is an approval for this. How do you address that? That's all I'm asking. I'm not saying should it be done. I agree. I actually feel we should write to FDA for at least EGFR positive tumor, for breast cancer with ER positive, PR positive, HER2 negative, grade 1, where TMBs can be 12 or 13 sometimes. We should write to FDA that how did you approve this when these patients didn't represent in the main cohort? But the point is, it is FDA approved, and how do you address that patient? How do you address that clinical situation?
Drops.
Okay, I think we'll leave it and we will discuss it over something else, because I have a very nice answer to this, but that's beyond the scope of this living. So is there any way? Definitely there is a way. So tissue, we are getting greedy. Tissue is an issue. With liquid biopsy, okay, this is something which I thought. So clinicians, as in solid tumor medical oncologists, are looking from beyond, and this is the Valentine's week, from tissue biopsy to a liquid biopsy. And at least Dr. Jyoti is smiling, and Dr. Jyoti, hold your smile for that, because you don't know this is the guy who is looking after this. So next question over here will go to the Professor Kumar Prabhash. Dr. Kumar, what is the potential advantage of liquid biopsy over tissue biopsy? And I hope nobody in your family is there when this slide was being played. Kumar?
Hi.
मार तो नहीं पड़ी?
बाद में पड़ जाएगी, आपको भी बाद में पड़ने वाली है।
पीछे का दरवाजा खुला हुआ है।
मैं बता रहा हूँ, मार तो अकेले भी पड़ती ना।
Okay.
So
potential advantages of liquid biopsy over tissue biopsy.
तो potential advantages तो बहुत सारे हैं. I think so. A whole lot of potential advantages is there, but that remains potential, and that's one of the challenge for liquid biopsy. What is for certain in today's time is that we have at the time of diagnosis information when you don't have a biopsy, and that is by not certain, and everyone agrees because specificity is so high. Second is that you do pick some extra. So the concept of if you are having tissue, then also you do it, and will you pick up extra? Looks like more and more data coming that it provides some additional information than what we had earlier, which was not the case earlier. So you do miss something in tissue, but you also miss something in liquid, but you also do miss something in tissue. And most of the time, what you pick up in liquid is the common mutations where you have a treatment there. It's not those very uncommon ones. Now coming to monitoring minimal residual disease, follow-up, and after treatment to follow up the patients who are to monitor the relapse. Those are relative potential, and that needs to be established.
Okay, so let's just ask Navneet. I mean, let's go to you. So liquid biopsy, there are a lot of myths in people's mind actually about that. I'm going to start because we had 40 minutes, so I thought we'll spend the first 10 minutes in making groundwork and then go to the more solid part of that. So what does liquid biopsy actually analyze? I mean, you have CTCs, you have extracellular vesicles, you have tumor-educated platelets, you have ctDNA, you have so many things. You have microsomes, exosomes. What does liquid biopsy for the benefit of the students here? What does it actually analyze? The one which you're currently using.
So very simply speaking, ctDNA is a component of cfDNA or circulating free DNA. So anybody, normal person also you check, you'll find cfDNA, but in patients with tumors, especially metastatic disease, you will find ctDNA, which is the DNA coming from the tumor cells. And most mutations are tested in ctDNA. For fusions which require ribosomes, I think you would require to do tested in exosomes. And CTCs are much less found compared to ctDNA. However, for PD-L1, the hope is really on CTCs when you're testing in blood. And obviously, I'm not a molecular biologist, but that is what I am grossly aware.
Absolutely agree that, for the purpose of practical knowledge, it is the ctDNA which is basically analyzed, and ctDNA is equal to, so cfDNA is a normal cell-free DNA which is found. The ctDNA is a tumor DNA which is basically being circulated. So let's look at this was the background of this, and let's look at the real clinical utility of liquid biopsy. This is what we would like to believe, but whether how good liquid biopsy is, in that we will see. So Dr. Kaushal, once again, what do you think is the clinical utility of liquid biopsy in non-small cell lung cancer in your practice, in theory and in practice? Dr. Kaushal? Okay. Dr. Vijay?
It actually catches another extra 15 to 20% patients. So if a patient is affording, I'm more inclined to use that baseline itself, both tissue and liquid. I have seen that many times the tissue doesn't show, but an additional something is picked up from the liquid. And I'm also inclined to, if the patient is affording, to get it after 2 or 3 months. We have data from our own study from Tata. It says that if there's a patient who is EGFR mutated, and if the ctDNA is not seen after 2 or 3 months, they actually do very well. So I actually do this for both baseline, for kind of monitoring, because sometimes the patients are really not very inclined at relapse to undergo another biopsy. So at relapse to see the resistance mechanism. So I put it at baseline and monitoring, and at the time of resistance.
Okay, Dr. Amit, if you are there, Amit Ratan, if you're there, how many times have you used, at diagnosis, we spoke about using a NGS. How many times do you monitor it to predict response, and how many you look at to disease progression and MRDs? How many times do you? These are four places, in addition to the screening, which can be liquid biopsy can be used for. How many times have you used liquid biopsy for all these things? Other places?
No. So MRD and monitoring as of now, no, that's not the place we are using it for. Definitely, in a EGFR, when it progresses, looking for resistant mutations, that's one place where we are definitely doing a second liquid biopsy. That's one place where I definitely find there is utility. These are the two common places I'm looking for it, at diagnosis and at progression.
1 and 3 is what you're looking at. Dr. Jyoti?
So I've used it recently, especially in those patients in whom the baseline molecular marker testing, see, I've been seeing patients for many years. So if that NGS, if the molecular marker testing was incomplete earlier, and now I suspect that, I need additional information and the tissue is an issue, getting tissue is an issue. So I found liquid biopsy come to my rescue, and it has been very fruitful. In fact, it has been able to pick up.
Dr. Jyoti, basically point number 1. That is for the biomarker detection.
And I'm not using it for, monitoring or MRD. And the only other reason would be to do T790M mutation testing or liquid biopsy if the patient has been treated with first or second generation TKI.
Okay. Well, let me go to some more daring people. Nitesh. And Nitesh will use liquid biopsy every day.
Yeah, I would love to use it every day, actually, truthfully. But not on the same patient every day. Not on the same patient every day. I would like to use it a different patient every day.
Okay.
Okay, so we all use for biomarker detection. I have really liked at least 2-3 patients where solid liquid has changed a little bit of my management, and that's been useful. But a very interesting area where I used was a patient who we were very concerned about, who had an ALK and a P53, and they were very concerned that this is a resistance. And we did it at 1 month, and we saw her cell-free DNA disappear, ALK disappear, and it remains non-detectable at 6 months, and a liver metastasis. So the biomarker monitoring, I think there's a good comment made from Tata that we are seeing now more strength in monitoring as well, and possibly we'll see some strength in early resistance and alerting ourselves to these groups as well. So at the moment, mainly for detection, certainly for detection at progression. But I do think that the monitoring will be a very strong aspect. MRD in future, I think we're all seeing very strong data come out of other tumors. So I think MRD, yes. Whether it will be tumor informed or uninformed, we'll see what the future brings.
So 1 and 3 definitely yes for most of the people. 2 is a plus minus, 4 is too early to say. That's the sense I'm getting.
Yeah.
Dr. Kaushal, are you here? What do you use?
Sorry, can you repeat?
Yeah, where do you use liquid biopsy in your practice?
Initially, we have discussed that when the tissue is the issue, I would like to use the liquid biopsy. That's the most important thing.
One number point.
Yeah. So
what about monitoring?
Sometimes the accessible site of the tumor for the rebiopsy is very, very difficult. Sometimes the old patients with chances of the high emphysema with the or pneumothorax, then at that moment I would like to go for the liquid biopsy for the molecular analysis. To monitor to predict the response, I think it's a little bit questionable at this moment. MRD is also one of the important things, but to determine the MRD in the solid malignancy in 2023 at present is also questionable. But definitely, the liquid biopsy has very much good utility compared to the past. And nowadays, I start to use liquid biopsy in number of the patient, particularly when the patient get a progression of the disease, because at that moment, sometimes the patient is not very keen or very fond to get the repeat biopsy because they are already burdened with the progression of the disease. So at that moment, I would like to go with the NGS with the liquid biopsy.
So stay with me, Dr. Kaushal. Out of 100 people that you see, lung cancer, let us say, how many people undergo tissue NGS and how many people undergo liquid biopsy? Just a ballpark figure. And I'll ask this
from diagnosis or all
somewhere in the course of their journey.
Yeah, so approximately 20% of the patient will get liquid biopsy and 80% will get the solid NGS.
Okay, fantastic. Nitesh?
Cost, no concern, 100% get liquid biopsy.
No. In your practice, in your real world practice.
So yeah, I think 50% will get liquid biopsy at some point.
50%, fantastic. 50 and tissue biopsy?
So almost all, 80% you'll try solid biopsy. Whether it's inadequate, then of course you go for.
Okay, fantastic. So 80-90 tissue biopsy, 50% liquid. Dr. Jyoti?
Up to 20%.
Liquid biopsy is fantastic. Dr. Amit?
Liquid would be about 80%.
80%, 80.
Yes, for us, lung cancer diagnosis, everyone gets a liquid biopsy upfront. Wow. That's how we send it. So we moved this a couple of years back.
Wonder
and
Bangalore,
we are very
Bangalore is the IT and the AI capital, so no wonder, wow.
So Ullas, no, I'm not saying everyone's getting a comprehensive NGS. Maybe it may be a limited liquid NGS, but we do liquid for everyone. That's the way we have been working.
Wow, that's fantastic. So 80, 20, 50. Let me ask Dr. Navneet. More sobering data, I hope, for me.
Yeah, so I mean, since the things which are available within the institute are EGFR, ALK, ROS1, PDL1 on tissue, that is done practically for everybody, barring tissue constraints. People who are negative by this are counseled for sending NGS outside. And I mean, amongst people in whom this initial testing is negative, maybe 30% of them would agree to send an NGS tissue outside. Liquid biopsy, EGFR positive, progressing on first or second generation, 75% will eventually undergo liquid biopsy for ddPCR for EGFR. Liquid biopsy NGS is going to be, again, a small percentage, 15-20%.
So when I said liquid biopsy, I didn't mean the T790M single genus. I meant the NGS.
Of 15%, max 20%, not more.
Vijay Patil, before and now?
Yeah, before it was less. Now my sample size is small, but it is nearly 100%.
Wow.
The sample size.
So from quantity to quality, not quality really, quantity to a very brief this thing. Fantastic. When? So let me ask Kumar, I'm going to come to you. I mean, till the time you sort out the video. When, Dr. Jyoti, again, when do you typically send a liquid biopsy? Out of the 30% people, do you send them at diagnosis or at progression, or when you are, running out of things? Just no explanation needed. Just give me because I have good cases coming up. So that is why.
No, at diagnosis, always prefer to tissue-based NGS, and only if tissue procurement is an issue. And the other scenario on progression, subsequently when the earlier testing was incomplete.
We heard Amit Ratan saying that he will send it for everyone, but most likely the feeling that I'm going to get for everyone is that, we will send it only if the tissue comes at insufficient, or maybe somewhere at a later cost, later time, when we feel ki chalo kuch aur kara lete hain. Is that the right statement that I'm making? No, Navneet.
One scenario where I would always want to test liquid biopsy NGS is when the diagnostic site was vertebra or bone.
So that's okay. That's absolutely all right. So the point over here is, what percentage of patients will you send them? And that's what I'm asking. The practice, the reasons can be different. So at diagnosis, we are sending in only 10%, barring Dr. Amit Ratan. Is that right? Nitesh, is that a fair statement to make?
I think we are increasing the liquid biopsy, solid liquid together actually. So the number is increasing.
So the answer me this now. Why so late and why so few? So 20% is not a good number, and why we normally send it late in the course. So what is it that
I think we are gaining confidence of it, picking up the right thing. Earlier we were not that confident. Now the more we've sent, the more we picked up, and where we've found solid tissue, in fact, we've had such high concordance that the areas where you can send only liquid, you would do that.
Dr. Jyoti, do you agree with that the confidence level was not very high? Now we are becoming much more better, faster, whatever, cheaper, maybe?
Yeah, I would admit here that with looking at Garden 360 data and the FDA approvals, there's more confidence now in doing liquid, and would rely on their report, and could be a replacement for tissue only if tissue is not procurable.
Okay, so maybe we are gaining more and more towards the, it happened with the NGS. We didn't know how to interpret the report. Now it's becoming more. So maybe now we are moving more towards the liquid biopsy.
True.
Okay.
One catch would here be, even if it is metastatic disease, the probability of picking up would also depend upon the spectrum of metastatic disease. So if it is an M1A disease, where it is just a malignant pleural effusion vis-a-vis extensive extrathoracic M1C disease, the probability of picking up something in blood is going to be much higher for M1C.
So I have saved my one difficult question for my favorite panelist, that is Dr. Kumar Pravash. Kumar, can you put on the video, please? if the video is still working and Bhabhi has not caught you with that video of that over there. Dr. Kumar, are you there? Okay, doesn't look like he's there. So let me ask this to Amit Ratan. Amit, are the various liquid biopsies by various companies? Let's say you have an Indian company by name of M. We have another company by the name of, by another international company by the name of A. And we have another company by the name of G. So is the MGF same? And if there's a difference, what is the difference? And how do you choose? Forget that you are in a symposium.
So that's you make it really difficult. So that's one thing. That's the difficulty with liquid, and that's where we have been always having issues. When we started doing liquids more and more and trying to pick up more, we started seeing variable reports from various companies, and that's where the difficulty starts from. Yes, if cost is not an issue, I would say someone picking up a good Guardant, a good FMI or something else is perfectly good, but that's something not accessible to everyone.
So can I just stop you 1 second for Amit? Amit, the other company which I said is very good in tissue. So this company claims they are good in that. So what changes? I mean, I want to know that.
See, that's where the difference is. The tissue we have standardized. Most of our companies in India, tissues we have standardized very well. It's the blood where is the issue, which starts from even the level of extraction, the level of collection, transportation, the level of DNA we are getting or not, and then the reporting. And we have seen huge misses. Believe me, we have had patients who have done liquid from 2 places together. When we try to do these so many times, last couple of years, we have made a rule that everyone gets an initial tissue biopsy, gets a histopath, send a liquid immediately, send a tissue also if they can access it. And we have seen huge misses and huge differences. So I think validation is an issue with all of us in liquid, and that's the difficulty.
So Navneet,
but we're getting better, I think.
Getting better. No doubts about that. We want to get even better. So Navneet, is there a difference between let me name the M, the G, the F company? What is the difference actually? Is it the technique, the sensitivity? What is the difference? Is it the RNA? When it came for fusions, people were not doing RNAs, and that was the difference. We put our finger onto it. Here, what is the difference?
This is analogous to what is defined as generic. So you can have very good generics and a very mediocre generics. And I have had experience with both. So I have had a so-called very famous advertising local lab and had horrible results with them, and very, very good and reliable results from other labs. And most patients in coming to us cannot afford to send it to either FM or Guardant. So I think it's in the absence of a head-to-head comparison, it is going to depend upon some amount of experience what you get with these labs and the consistency of their reports. But having said that, the advantage of sending it across to US at phenomenal cost is getting additional information which some of the local NGS panels may not be able to give you. But 95% of samples from our side will go to national labs only.
Okay. So now we come to this algorithm actually, so there was
make a quick,
sure,
can I ask a quick question actually? So I don't know the answer to this. Last year better at answering because you worked at your own lab also. But my feeling is that first with solid, we learned our way through, including the labs learned their way through. And then with liquid, we are seeing the labs learn their way through. And so some labs, and I will include some very foreign big labs, big cancer centers in New York, starting at them, also were missing on solid tissue what Foundation was catching initially, right? So what I'm saying is that this is a process. The lab's quality over a period of time as I'm watching has increased, and I'm very glad that the cost has come down even in the last 4, 5, in fact last 2 years, of very much higher quality and much lower cost across many labs, not only the 3, 4 you're naming, actually even others, we can see the cost come down. Problem is, I recently had a new lab come in and say, please do that. I asked them for some reporting. I sent it to a colleague of mine. He and she, two people, they looked at it and they came back with some information I was completely unaware of. I was saying Illumina, it will work. But then they came back with some such in-depth analysis, it made me scared about this new lab. Yeah. So I don't think we understand this science well enough as clinicians, and we should take guidance from other labs, molecular biologists, and get them vetted. And I think that's the smarter thing to do.
Okay, so since we have only 10 minutes remaining, Nitesh, I'll stick on with you only and ask you. There were 2-3 approaches. There's a plasma first approach. What Dr. Amit Ratan was saying, send liquid biopsy for everyone, tissue biopsy report will come or not. The second is a more sequential approach that what we are using, you tissue biopsy doesn't come, then you do the liquid biopsy. Third is the complementary approach. Use both. Are you convinced regarding this complementary approach, and that is what is coming out?
I would do complementary till at least PDL1 is available on liquid and equally good. Till that time, complementary is extremely important. We can't do it sequential based time, but if not possible, then of course biopsy is a must, because I must have a PDL1. I can't rely on.
Is it only the PDL1 that you are bothered about, or is it the sensitivity of liquid biopsy?
No, I'm very confident of liquid biopsy picking up the right targets now. So if you give me a liquid biopsy and that's EGFR ALK positive, I will not want a tissue to do PDL1 in those patients.
You're not bothered about missing out on. You're saying if it's positive, it's positive. That's what you're.
Yeah, even if PDL1 is positive, I'm not going to treat that patient.
Jyoti?
See, complementary would be the best.
Okay.
But sometimes we do sequential. Yeah. Often we do sequential.
Mostly we do sequential. I would probably say that. Okay, Dr. Kaushal?
Yeah, the same. I agree with the both of our panelists. Complementary is the best, but we do in our clinical practice mostly sequential rather than the complementary to each other.
Vijay?
Complementary, but I think liquid misses sometimes. The tissue adds it. So I think both are required.
Okay, so this is some data about liquid and tissue, which I think we will go about. This basically, like what everybody is saying is the tissue, all the mutations. This was Nile study. Tissue basically picked up 67%. CFDNA picked up 87%. So liquid actually picks up more. That is what was there. This is a complete study which basically says that you have the equal value, the positive predictive value. What Nitesh was saying, that if you have EGFR ALK positive, you don't want to do confirm it basically by that. This was Sanjay Popat study, and I'll just leave on to this. This is again one study which basically says if you do both, your again your survival actually becomes better because you actually pick up more mutations, and that is what is there. Now, what I want to ask you is, do you think, Navneet, in your practice, if you have a ALK4 with a VAF of, let's say, 0.4% on a liquid biopsy, would you want to confirm it on the tissue? And do you think a 0.2% of VAF, does it work equally well? Will you be happy in giving lorlatinib or alectinib in this?
If tissue were available, the blood wouldn't have been sent anyway.
No, complementary approach. The tissue will take time. Liquid biopsies come in 5 days time. Will you give alectinib or not? Or will you give some chemotherapy?
I'll just wait for 5 days for the ALK is IHC, right? So if both have been sent simultaneously.
Ross kar lete hain.
Whatever.
Let's do.
So if both are available.
So I am saying only a liquid biopsy report is available. Will you want to, are you confident enough in starting a patient on a liquid biopsy report, especially a fusion report? Are you happy starting that? That's a very simple question.
So tissue is not available and rebiopsy is not an option, right? You just send the blood and it comes out as positive. If it is from one of the labs I trust, which are most of them are, I would start.
Okay, Dr. Jyoti?
Yes, I would start based on it.
Yeah, I will definitely like to start the treatments on the liquid reports.
Amit Ratan definitely will start. Dr. Amit? You haven't
so this is the tricky part, This is where we come down to which lab is it, what it has reported on that liquid NGS, and that's where the whole tricky part is coming. So we had a recent squamous which was reported on liquid as an EGFR. I know we will have EGFR, we know it, But on a liquid, when you have an EGFR and a squamous, I was worried. So I did the tissue and then it was not there. And then we looked at it, even the PCR was not there. So these are issues. So when you have a liquid, you need to be very sure, like you need to have that confidence in the lab. And I think that will come with each of us choosing our own labs where we are comfortable with and we have validated it ourselves. And that's the tricky part. And I would agree with the thoughts, it's not straightforward. I would agree with that. So somewhere some of these you can, some you can't.
Okay. But by and large, if you have acted on the liquid biopsy and you're confident of the lab and the mutation, by and large, the results are okay. This was initially was a FastSec study, which I showed you. This was a vision study in which the MET exon 14, if you detected by a liquid or tissue, was the same. Okay. And now this is a patient which I have, which we will do later. But this is a more important patient that I will do. This is important. This lady has been taking a lot of opinions. So this is a patient, 65-year-old female, non-smoker, no family history, stage 4 non-small cell lung cancer. NGS says no actionable mutation, P53. This was done in-house at RGCI. 3 cycles of, I think PDL1 was 50%. We gave 3 cycles of Pembro, Pem-Carb, symptomatic improvement. However, the PET scan showed a progressive disease with new lesions in the adrenal. We got a biopsy done. It came as poorly differentiated adenocarcinoma. We put her onto chemotherapy because the initial was there. It was weekly Paclitaxel that we started with. But we also sent for a repeat liquid biopsy and tissue NGS. And this is what the basically report shows. And the report basically shows in the liquid biopsy, the present G liquid biopsy, you have a BRCA1, BRCA2 mutation with a cfDNA fraction VAF of 0.4%. Similar time, a tissue biopsy was done, which is showing a TP53, which was there initially. So again, stage 4 NSCLC, 3 cycles Pembro Pem-Carb, initial biopsy, we had done it RGCI, P53, progression now has a BRCA1 0.4%. Now tell me, Dr. Amit Rautan, what do I do?
See, when you see a BRCA, you're very suspicious. Why would a BRCA be one of those? So this is not one of the mutations you'd want to really jump on saying this is there and we'd want to target. So I think I'd worry about this. I would not say I would treat a BRCA I picked on a liquid. I would say look at your tissue also. BRCA is not one of the driver mutations for lung cancer.
Tissue has come as TP53 only, no?
Yeah, so exactly. So that BRCA could be you're picking up noise. This is where the lab reliability will come in. If there's noise.
This is your reliable lab only, Dr. Ahmed. This is a reliable lab. This is what we are talking about. This is a garden lab. The garden.
So I would agree. Now look at this. So the next thought comes: is this germline? Let's do a germline testing and look at it. Is this somatic pure?
The lady, the husband wants me to start olaparib tomorrow. My problem is that he's coming tomorrow to start. What do I do?
I would say this is not a targetable mutation in lung where we should jump to it. If it turns out germline, my temptation changes.
But it's just 0.4% of VAF.
Yeah, so it's not going to be germline. So it's definitely not going to be germline, right? So it's somatic. I don't think in lung we should really go and say that we should target this directly. It's tough to say this.
Okay, so Dr.
Last you must have looked deep into this, and I know that you know that BRCA as a somatic mutation appears but should not be targeted.
Yeah, that's right. But the point over here is, okay, I'll take everybody's opinion, then I'll come to what I'm going to say. Dr. Kaushal?
Yeah, I am more or less agree with Dr. Amit, though it is a positive, but it is not targetable for the lung malignancy at present.
Okay. Vijay is not there. Kumar is not there. Navneet?
Yeah, it's just bystander noise. Nothing to do.
Bystander noise. Why do you say bystander noise? Or let me just reframe this question. If this were a MET exon 14, then what would have happened?
No. MET exon 14 not present initially in tissue, not present currently in tissue.
Yes, and only on liquid. Then no, but my point is, Dr. Navneet, why do you say that 0.4% of MET exon 14 is not a noise and this is a noise? Just because it is not following the biology. Then what is the point of having a CGP?
Negative markers don't turn positive, positive can turn negative. That is the general dictum. That was also there in the consensus document. If it wasn't there initially, it's unlikely to be now there as a
Might have
true.
missed it, no? I mean, that is what we might have missed it. I mean, so that is also something which was there. I will show you this case also. There's another patient in which it was not there initially because probably the lab was not very good. And there are two patients of mine who have been found to have a liquid biopsy positive, a MET exon 14 positive. After treatment, I have given capmatinib to both of them, and the patient has done extremely well. So whether my initial NGS missed it, I don't know. So my point is, I don't know why a 0.4% of, this is what I am telling you. This is what the same thing, 0.6%. This was a negative one. This 0.6%, we are saying it's a positive because it is suiting us. MET exon 14 hota hai lung mein, we know that. BRCA nahi hota hai, so we are saying it's not there. So that's
The VAF is not the issue.
okay. Then what is the issue?
The blood in circulating blood, VAF of 0.6%, 1%, 0.5% is okay.
So
what is important is whether if your initial testing was appropriate, and so if your initial NGS testing was tissue and appropriate, and you have another tissue which is also negative, and you are picking this up only in blood, I would have to look, I mean, question the whole thing, that why was it not there in the initial tissue?
Isn't this the advantage of liquid biopsy, that the intra-tumor
exactly.
heterogeneity and the intra-tumor heterogeneity? That's what liquid biopsy says they do. I mean, so
yes, but tissue heterogeneity increases with time. It is the least at diagnosis. So if you had a tissue NGS at diagnosis which did not pick it up, and you have done liquid plus tissue at progression, and the tissue again does not show that, and it is only there in liquid, I think it would need some discussion on that.
Full searching on that. Dr. Jyoti.
See, for MET, I would act, but for your BRCA too, I would wait. Use more standard second line treatments before jumping on
third line. Give it in the third line. That's what you're saying.
Yes.
Okay. And Nitesh?
And one more comment, Dr. Ulas, as Dr. Navneet was also saying, so considering that tumor heterogeneity, that issue will remain even on progression, and it's possible that the liquid biopsy may pick up something which has been missed earlier and now on progression also, isn't it?
Okay.
So that's possible.
Fair point. Fair point. Everybody has a fair point. Okay, Nitesh, your comments on this? Nitesh also has logged out. I think, by the way, people are logging out. We need to now probably, stop the discussion. But I mean, it's a fantastic way. I mean, so just last comment from there. If money was not an issue, would you send a complementary tissue and liquid both at diagnosis? We'll start with Dr. Jyoti. If money is not an issue, will you send at diagnosis both tissue and liquid?
Yes.
Okay. And Dr. Navneet?
So if I had to send both out, I would just do the whatever is available in-house, EGFR, ROS1. If I pick up anything, I would not do, but if both were negative, I would send both a tissue and blood simultaneously.
So I think the issue over here is that we are basically bothered about the cost. I mean, we are okay with the science of that, the commerce of that is what we are not okay with. Is it right, Dr. Kaushal?
Yes.
So I think, yeah, I think by and large, we all agree with the statements. And I think with this, I would like to thank everybody for being a fantastic panelist and having a good discussion. Hand back to the organizers.
Just one quick question, if I may ask to Dr. Amit. Are you doing away with tissue biopsies? Ever in near future?
Dr. Amit is logged out.
Because he said, oh.
He is also logged out. I think it's
Do you see that happening, Ulas? Do you see that happening for lung?
No, not at all.
Never.
I don't think so. I don't think so. I think tissue biopsy, and my last slide over there actually is unfortunately not coming up. So I don't think you are going to replace tissue biopsy. The complementary, the way is the way to go. You may pick up some things in tissue. You may pick up some things in liquid. That's the way it is going to be there. So with this, thank you. It was a wonderful session. And I'm sure, as I was saying, we are all learning, we are all evolving. And initially getting an NGS was a big ask, but I think now everybody is getting this thing. And I'm sure in 2025, 2027, we are going to have more liquid biopsies as a complementary diagnostic tool to tissue biopsy. So with this, thank you. Thank you, Gordon. Thank you all my panelists for a very lively discussion. Thank you.
Thank you so much, sir. Thank you everyone for your